Sarah lives in Kingston, and she's a strong and bubbly person. Except for about a year, something changed in her, and she feels quite exhausted. Not very much willing to eat, so she thought this was a phase, and she would just push it, she would just shake it, but it wasn't really going away. But nevertheless, she showed up for work. She did her best. She showed up until she couldn't anymore. And one day she broke down in front of her mom, at which time she agreed to go see the doctor. The doctor listened to her sympathetically and prescribed an antidepressant and said, let's try this for about 6 weeks and hopefully this will help you. Sarah was upbeat that day, but she wasn't 6 weeks later because the antidepressant didn't really make a difference. So the doctor said, well, okay, let's try another one. This is a different family of antidepressants, so we'll try this one and hopefully this is going to work for you. And that didn't work either. So after the third trial, the doctor agreed to refer Sarah to a psychiatrist. Sarah was again crushed when she found out that she had to wait for 14 months in Kingston to see a psychiatrist. Now, this is not a unique story. Many of us would have known someone who went through something like this, or maybe we have, some of us, gone through this. What I know is that 6.7 million Canadians suffer from something a condition related to mental health annually. Now, what does this have to do with a business school professor? I am trained in operations research and management science to tackle complex and multifaceted problems, and what can be more complex and multifaceted than Canada's problems in healthcare. So that's what I specialize in. It's a fantastic field because everything is so difficult. I have worked at McGill University in Montreal for more than 2 decades at the beginning of my career. And there I worked with most of the tertiary hospitals, of course, in the English side. And we have done some work at the Jewish General Hospital where we developed a simulation program, which is called a digital twin these days. We work with their surgical services department to balance the nurse workload. But for the purposes of today's talk, I think the most relevant work I did in Montreal was with the Douglas Mental Health Hospital on their clinic for the treatment-resistant depression patients, and with the Jewish General Hospital for their continued care clinic on the schizophrenia patients. From Montreal, I moved to Lansing, Michigan, to become a department chair. And I did that for 3 years. Those 3 years coincide with COVID. All of our medical partners were fully occupied saving lives. So I have absolutely no research results to report on for those 3 years I spent at the Michigan State University. And so then I joined Queen's University Smith School of Business 3 years ago. And upon arriving, I wanted to develop my network of connections in the health space. And that's when I met the people in the adult psychiatry division of the Kingston General Hospital. They have an online psychotherapy lab there where they have developed more than a dozen digital modules that could be used for providing online cognitive behavioral therapy. And that expertise actually establishes the foundations of the work we did with them afterwards. So our medical partner in this space is the adult psychiatry division of the Kingston General Hospital. And this piece of art is actually supposed to show you, just in case it's too modern, that you need a team to deal with these kind of challenging problems. And the challenging problem you see there is the waiting line. So in addition to the medical partner, I also met a technology partner where it's called OPTT Health, and they develop large language models specializing in psychotherapy and psychiatric triage. So it is this team of 3 sub-teams where we have the management school, the technology vendor, and the medical side. We worked on developing an AI-assisted triage program to deal with the 14-month wait time for the patients at the Kingston General Hospital, where there was 1,200 patients in the lineup. So when you're referred to a psychiatrist at the Kingston General Hospital, there is 1,200 patients roughly in front of you. So this is my most impressive slide. If you're not impressed with this, then it's going to be downhill from here. So this is the process flow of the care delivery for patients of the psychiatry division. And as you would see, from the left, the patient is referred to the psychiatry division, and a triage starts the process. That triage takes, on the average, 45 minutes by a registered nurse. And so basically this particular research project I'm talking about today is to replace that in-person triage with an AI-assisted triage that the patient will do online. And so that at the end of that triage, where the technology vendor's large language model is utilized to go through the patient's narrative in terms of the symptoms they're feeling and the changes over time. So basically, the patients are able to either voice record or type the narrative, and then the large language model analyzes or text mines that and identifies 3 different care intensity levels and disorder-specific psychotherapy tools to the patient. So these 3 this is what I'm talking about. And then once the patient actually completes this, then the patient is directed to a 10 to 12 week online cognitive behavioral therapy tool. Now the care intensity changes from mild, moderate, and severe patients in the sense that the mild patients need to, the target is that the mild patients will see the doctor in 6 months. The moderate patients will see the doctor in 3 months, and the severe patients will see the doctor in 1 week. And the other thing, so basically, as you can see after that rectangle, it splits into 3 pieces. And the other difference between the mild and moderate and severe patients is that the higher intensity 2 groups involve the weekly meetings, virtual meetings with the therapist. Right? So the mild patients only do the cognitive behavioral therapy. The moderate and severe patients, in addition, are overseen by a therapist. And in terms of the target, one needs to see the patient, the physician, if necessary, in 6 months, the other one in 3 months, and the other one in a month. Now, what I forgot to mention is that at the triage, one of the things that's done is that it's also trying to identify the high-risk patients who need to see a psychiatrist immediately, right? So if you are a high-risk patient, then the AI-assisted triage would flag the care team, and you would be directed to a psychiatrist immediately. So this is the setup, and what we have done is that we have recruited 100 patients out of those 1,200 patients waiting in the line who would agree to use the AI-assisted triage. And upon completing the 12-week psychotherapy, some patients did not need to see a physician, a psychiatrist, and so therefore they were referred back to the primary care physician who referred to them to the psychiatrist. Some patients needed to see the physician, and they were directed to the psychiatrists in terms of the urgency of how quickly they need to see that. So, as a result of this, we were able to cut the 14 months wait time to 8.5 months. That's a 5.5 month reduction in the wait time. And the key here is that we were able to take out the patients who did not need to see a psychiatrist out of the waiting line. And that turns out to be 2/3 of the patients. So it's the 1/3 who really needs the higher intensity level of care, and the ones who need the higher intensity level of care, we're waiting for those who were referred to the system because their primary care physician didn't know what to do with them, right? So basically, the patients have waited for the pilot study, the 100 patients. They're waiting less. The 45-minute registered nurse triage has been taken down to 6.5 minutes. The weekly visits with the therapist, which were an hour each, were taken down to 15 minutes. And this means that those care providers are now able to free themselves up from these tasks and provide access to other patients, right? So it is good for the patient, but it's also good for the care providers. There's also an economic perspective to this, in that we were able to estimate a $17,000 saving per patient, which basically totals up to about a $2 million saving to the economy. Most of it does not come from the savings you achieve in the nurse's time. Most of it comes from the productivity that you prevent from losing by providing treatment to these people much earlier. So that's where the savings are, not that you reduced some nursing time from 15 minutes to 7 minutes. Now, most importantly, the 3 high-risk patients in the 100-patient population that was identified by the physicians was also identified by the AI. So the AI actually performed amazingly well in terms of identifying the high-risk patients. We also have compared the AI's recommendations with the psychiatrist who looked at the same patient's triage and said, I will call this a moderate patient, and I recommend to see this patient to see a physician in 3 months. Those matched the human psychiatrist's assessments 75% of the time. So the AI worked with a 75% accuracy and achieved a significant reduction in the wait line by identifying correctly the patients who would benefit from cognitive behavioral therapy but not necessarily need medication to be prescribed by psychiatrists. Now, where do we go from here? Well, I would like to develop a slide that's even more impressive than this. But the idea is that this waiting line in the psychiatry division is happening because 40 to 50% of the patients who went to a family physician, if they have one, and if they don't have one, they'll go to emergency. They will have to go to emergency department, are referred to a psychiatrist. Let me repeat that. Half of the people who express they have a mental health condition will be referred to a psychiatrist by the doctor, family, or primary care provider. So what we would like to do, or what we are working on doing right now, is actually focusing on the left side, the initial phase of this, where now we would like to help out the primary care physicians with the AI-assisted tool so that they could actually do better in terms of determining what path the patient should follow and whether the patient really needs to be referred to a psychiatrist or not. Because if you don't keep referring the patients to a psychiatrist when it's not necessary, and in our case, about 60 of the 100 people actually was those cases, then maybe you'll have a much shorter waiting line. And so the people who really need intensive care will be able to receive that care. Now, this is one effort that we're focused on right now. And the other one is, of course, we're focused on scaling up the pilot study to make a difference in Kingston General Hospital. To the extent that we would do that, maybe the next Sarah, maybe the next, sorry about that. There's an even more impressive animation in that slide where Sarah smiles. Now, I was here at 4 o'clock and we did 2 rehearsals. We never managed to make Sarah smile because the slides were done at Queen's, and of course we're using a different computer here. But at the, so maybe the next, oh, she did? Right, she did. Well, if you wish, it happens, right? So maybe the next Sarah, to the extent that we could do this, is not going to wait for 14 months. Maybe the next Sarah will be able to have access to timely and the correct intensity of care in a much more timely fashion. This is the type of future that we're trying to build. It's not because we replaced human care with AI, but it's because we amplify human care with AI. And that's important because no one should wait to be heard. Thank you.